Dispelling women's healthcare myths. Is that this is actually a very important area of medicine and how to find out how to treat heart disease and other disease process. So I'm really happy that the team is going to be talking about this tonight. As you know, most of these things are recorded Friday live, so I'm going to be having some dinner tonight. I hope everybody's going to have a healthy food, and let's hear what we have to talk about.
All right, so I'm here today with Hania as part of the Women's Cardiovascular Health Club, and we're going to be addressing some myths and misconceptions regarding women's health. So we'll be starting off with a brief introduction, and then we'll be talking about some heart health myths as well as some pregnancy myths. Then we'll discuss menopause for a bit, and then we'll end off with some myths about body image. So before we jump off into the myths, I want to briefly discuss why we're talking about this topic at this moment in time. And as you may or may not know, 3 days ago was actually International Women's Day. So International Women's Day is a global day that is intended to celebrate and commemorate all the contributions of women in areas of society, economy, policy, healthcare, all sorts of areas really. And the theme for International Women's Day for this year is Break the Bias, and taken from the International Women's Day's official website. The quote runs, "Whether deliberate or unconscious, bias makes it difficult for women to move ahead. Knowing that bias exists isn't enough, and action is needed to level the playing field." And so we kind of were inspired by this message, and we decided that we will be addressing some aspects of gender and sex bias in healthcare. So clinically, it's been shown that there's more inclination to dismiss women's symptoms. This is due to the larger societal perception that women are more emotional, that they tend to exaggerate pain. Historically in research, there has been a lack of gender and sex specific research, leading to a lot of results that were found that weren't actually even applicable to a good portion of the population. But fortunately, we have been making some progress. There's a lot more that we have to do, but we've been gathering understanding on a number of issues that have to do with gender and sex and health. And we're here today to try to share some of that with you, to try to counter the misconceptions and myths and address the biases. So I'll be passing it off to Hania, who will be talking about women's heart.
Could you just backtrack one slide there? So kind of interesting is that I don't know physicians going out of the way to dismiss symptoms because you're male or female. I do know that women's presentation of heart disease is more difficult. And one of the things is that males are more likely to present with a classic heart attack or sudden death, much more easy to recognize. And where women present with more atypical features that we're going to talk about in a few minutes from now. So I think it's just hard to make the diagnosis. And there's something called the microcirculation. We have a previous webinar on that, is that we're very good at looking at the angiograms and looking at the big vessels, but the smaller vessels these are new areas of research, and women seem to have a higher prevalence of those types of problems. So I'm thinking it's just hard to make a diagnosis. It's a big problem, but we'll learn more.
And Dr. Curnew raises a very good point. We'll be discussing more of that later. And also, you also raised the point of conscious versus unconscious bias in healthcare. I think a lot of the gender and sex bias, not just in healthcare, but in the world at large, is unconscious. And that this is why we are doing kind of educational materials that will address these kind of aspects of unconscious bias. And so Hania will be leading us off.
All right, so let's delve into the first general myth that we're going to go over, which is the topic of women's heart myths. We can go to the next slide. So the first myth that we're going to cover is that heart disease is a man's disease. So we can go to the next slide. To note, heart disease refers to several different heart conditions. So this can include coronary artery disease and heart attacks, just to name some notable ones. There's a misconception that heart disease is a concern that only men have. So this misconception has been propagated through common societal stereotypes, which have been supported by mass media, such as TV shows and movies. So usually it is a man or a male actor who gets a heart attack or gets diagnosed with a severe heart disease. But in reality, the Center of Disease Control and Prevention indicated that almost as many women die because of heart disease as men in the United States. In fact, Harvard Health indicates that since 1984, more women than men have died each year from heart disease. Heart disease is the leading cause of death in women over the age of 65, just as it's the leading killer of men. So as you can see on the graph that's displayed on the graph, the prevalence of women facing heart disease between the ages of 60 to 79 is actually slightly higher than men. So by that age, 71% of women are facing heart disease compared to 70% of men. And then between the ages of 80 and above, women are once again facing heart disease at a slightly higher percentage, which is around 87% compared to the 83% in men. So we can go to the next slide. It is important to note that there are some caveats to these statistics. So as reported by Mosca and colleagues, men are more likely to be diagnosed with coronary heart disease in particular in comparison to women. So this is shown by the graph as the gray arrows are all above the white arrows, which represent women. So for example, between the age range between 75 and 84 years old, 59.2% of men were diagnosed with coronary heart disease versus 40.2% of women. We can go to the next slide. However, more women die annually to heart disease in general, as indicated by that line where the arrow is pointing towards. So this is all to say that heart disease is not just a man's disease, as it impacts women at high rates as well. So we can move on to the second myth. So the second myth that we're going to discuss is a common misconception that men and women present with the same symptoms for heart disease, something that Dr. Curnew alluded to before. We can go to the next slide. So in actuality, this is not the case, as women often develop symptoms that are more subtle and harder to detect when it comes to heart disease, according to Johns Hopkins Medicine. So some traditional symptoms that are common in both men and women include chest pain, shortness of breath, chest tightness, and just some overall pain. Whereas women in particular may present with less common symptoms. So this can include indigestion, back pain. Also, women often develop heart disease without having any of the obvious chest discomforts. They're also seen to experience nausea and vomiting, as well as fatigue. So we can move on to the next slide. There are also some...
Go back that slide there. So, is that you have something called typical angina, where if you get this tightness in your chest when you walk down the street, it feels like a heaviness. It's not a pain, doctor. It's a weight comes on with activity. You call that typical angina. That's more likely to be blocked arteries. Men present more with this. Also, too, women present with these symptoms. They may not have their arteries blocked to the same degree as men do as well. So things like indigestion, back discomfort, nausea, vomiting, all these sorts of things are very non-specific symptoms. It could just be a bad cold. It could be a backache. Also could be heart disease. So I think we have to have our antennas there. So when I think of these symptoms, I think about the age of the person, because women tend to have heart disease usually about 10 years later compared to men. And if you have high blood pressure, your diabetes, you smoke, you have high blood pressure, that puts you in a scenario where we're looking at heart disease. So it's really thinking about how to make these right diagnoses, and it can be hard. And you still can have back pain, and you can still have indigestion. So you can see how much of a challenge it can be at times. That's why we have to be careful, but we don't want to call every ache and pain heart disease as well. So that's the job of healthcare providers, and you to help figure this out too as well. So to me, it's a changing pattern. If you've had indigestion, these nausea, vomiting for the last 20 years, you probably don't have heart disease. But if you start to get this nausea, there's some exertional effect, I'm sweaty with that. And that's new. Makes me think of heart disease, especially if it comes on with activity. Not always, but those are the things that make me think about that. Go ahead.
All right, so next we'll talk about a little bit of the risk factors for heart disease that women face that men don't necessarily face or not as common. So in general, the leading risk factors for heart disease for both men and women are, as Dr. Curnew alluded to, obesity, smoking, diabetes, high blood pressure, and also a family history. So if you have one or more of these factors, you're more likely to experience heart disease, or you may be more at risk to. Some risk factors that are a bit more specific to women include relatively high testosterone levels prior to menopause, as well as increasing hypertension during that menopausal area. Also, stress and depression, which are more common in women, and so those can also be factors. We can go to the next slide.
Well, keep that slide there. This is good. So we let's go back again. There's two patterns of being overweight. There's that central, that tummy fat. That's more related to heart disease, where the weight on the thighs area is less metabolically active. That's less likely to cause heart disease. It looks like women pay a higher price for smoking compared to males. And diabetes affects women worse so for heart disease compared to males. And high blood pressure is an equal killer in both males and females. So, to me is that if you look at some of these risk factors, well, I can't change my family history, but I can certainly change my weight, my smoking, my diabetes, my blood sugar, my blood pressure, and my cholesterol. So really think about how you can control these risk factors so you don't develop heart disease. Now, depression, stress, these are things that we're all facing at higher levels, and they're very important. And one of the things I'm learning is that most of us have about 20 to 50,000 thoughts that flow across our minds every day, most of them being repetitive, unpleasant. Learn to deal with them a little bit better. I'm really grateful for our mindfulness group. And, one of the things is just being grateful. What are the three things that you're happy or joyful today? Makes you live longer. Surround yourself with happy people as much as you can. And do something about your stress. It's not necessarily pills. It's basically just that approach of being grateful, and also meditation, relaxation. Now, they don't cure everything, but they sure make a huge difference. And I'm really grateful to Dia, Hannah, Jerry, who run our mindfulness meditation group. Every Wednesday at 7 o'clock, you're all welcome to join us. I feel better at that group, and they've helped me a lot, and they can help you too as well. So let's not just identify the problem, let's actually solve the problem. A lot of these things can be improved. Go ahead.
All right, so the last myth in this section that we're going to cover is that heart disease affects men and women the same, when in actuality it does not. So we can go to the next slide. So, for example, heart disease often develops later on in women, and this phenomenon has been attributed to the impact of menopause, although specifics of this concept are still being investigated and researched. But it is thought that the hormonal changes that occur during menopause can lead to increased risk of higher blood pressure and cholesterol levels, which could ultimately lead to heart disease if not managed. Also, coronary artery disease, which is caused by cholesterol building or blocking arteries, usually occurs in larger arteries in males, while in women, this usually occurs in smaller vesicles on the wall of the heart. So again, this makes it more difficult for women to be diagnosed with heart disease and could potentially prolong treatment. So overall, there are differences in the way that heart disease impacts men versus women. So we can go on to the next slide. So we're going to look at our second sort of general myth, which is reproductive health myths. Next slide. Now, there are several reproductive health myths, but today in this presentation, we're going to be focused on two in particular. And the first one is the misconception that vaccines are not safe during pregnancy. Go on to the next slide. So the Center of Disease Control and Prevention stresses that certain vaccines are not only safe, but are vital in keeping both the mother and baby safe. So vaccines allow for mothers to develop antibodies, which are kind of like defense systems within your immune system that not only protect the mother, but can also cross the placenta to help protect their babies from serious diseases. Vaccines during pregnancy can also help the mother avoid getting certain diseases that could negatively impact their health and ultimately the newborn's health. So it is important that pregnant women double check with their doctors if they plan to travel anywhere in particular where certain vaccines are required. There are two common vaccines that are recommended for pregnant women, which are the flu vaccine and TDAP or Tdap, which is used to protect against whooping cough. So we can go to the next slide. The Mayo Clinic also indicates that the COVID-19 vaccine is recommended for pregnant women, as studies have shown that the vaccine doesn't pose any sort of serious risk. These findings were supported by research conducted by Kim and colleagues that observed that the COVID-19 vaccine had no obscure risk within the 35,691 participants that were looked at. So in the graph on the slide, it indicates that the known symptoms of COVID-19 vaccines were quite comparable between pregnant and non-pregnant individuals. So either groups weren't impacted drastically different. So overall, inactive viruses or vaccines in particular are safe during pregnancy. We can go to the next slide. So the second myth is that exercising during pregnancy is unsafe. We can go to the next slide. Exercise is actually recommended to expecting mothers as it can reduce backaches, constipation, bloating, swelling. It can also boost one's mood and energy level, also help with sleep. It also allows for a lower risk of gestational diabetes for some, among some other added benefits. It is important, though, that pregnant individuals reach out to their doctors to ensure that it's okay, because individuals that may be struggling with different forms of heart and lung disease, preeclampsia, which is high blood pressure that develops for the first time during pregnancy, and cervical problems may limit a pregnant individual from exercising in a sort of aggressive manner or regularly. So just double check with your doctor. But overall, the Mayo Clinic advises that expecting mothers should try to have at least 30 minutes of moderate exercise a day. That can include swimming and running, or just other sort of low stress type of exercises. But of course, it's always important for individuals to pace themselves and make sure to take breaks, especially when feeling dizzy or lightheaded. It might be time to take a break and maybe stop exercising for that day. But overall, exercise can be beneficial during pregnancy. And now I'll hand it off to Dong.
All right, so the next section of myths that we'll be addressing are menopausal myths. And so there's actually a lot of stigma surrounding the topic of menopause. And there's also a lot of lack of awareness surrounding menopause. There's a common perception that menopause just starts when period stops and it's over in a matter of months mostly. It seems really straightforward. It's just the ending of the period, and it seems pretty consistent across the female population as well. So what's the fuss? The reality is menopause can be a really lengthy and varying experience. The definition of menopause itself is actually 12 consecutive months without a period. And this is actually preceded by an average of 3 to 4 years of what is known as perimenopause. So we can take a look at this graph to the right here. And we're starting off with essentially, I guess, the beginning of a woman's life where estrogen levels are at a higher amount. And estrogen is the female sex hormone. And estrogen, when it gets to about 35 to 45 years old, it starts to drop. And it doesn't drop consistently, it drops in a fluctuating manner. And then this is the stage of what is known as perimenopause. And these fluctuating hormones can lead to a number of different side effects, such as vaginal dryness, irritability, and hot flashes. And it's only after a whole year of not getting a period that women experience complete menopause. And so the experiences of menopause actually vary a lot depending on the type of menopause. So what I just described there was natural menopause, where women, after reaching a certain age, their estrogen levels start dropping. However, there's also surgical menopause, where people receive oophorectomies or hysterectomies, where they get their uterus or ovaries removed. And naturally, the kind of experience that people go through will be very different depending on the type of menopause. And the time of onset can also greatly vary. So the average age of reaching complete menopause is 51 years. And as I mentioned before, perimenopause usually precedes that by 3 to 4 years. However, perimenopause can be up to 10 years before actual menopause. And the age of getting actual menopause can also vary greatly. About 1 in 100 people actually get menopause before the age of 40. And this is known as early menopause and also has its own associated set of risks, which we'll discuss a little bit more. Menopause actually also very much differs depending on the individual, as you can imagine. Certain individuals might not experience a lot of symptoms, whereas other individuals might experience a lot of different symptoms associated with menopause and being very greatly affected. So now that we kind of have an understanding of everything that menopause is, and that it's not just really a switch from having periods to not having periods, why is there a need to discuss menopause? There's still the common misconception that we have to talk about it, that it's a little embarrassing to talk about. No one wants to discuss uteruses, no one wants to discuss periods. But actually, menopause is really important to discuss because of the way that it affects the rest of the body, among other reasons. So menopause has a lot of heart implications, and it's been seen that there is actually a rise in coronary heart disease incidence after menopause. And this isn't because menopause causes heart disease, but because, as I mentioned before, the estrogen levels drop during perimenopause and into menopause. And estrogen is actually protective of the body. And when the estrogen drops, we see an increase in blood pressure, an increase in LDL, which is the bad cholesterol, and we also see a decrease in HDL, which is the good cholesterol. And so these kind of risk factors are going to lead to an increased risk of getting many chronic diseases. Early menopause, so getting menopause before the age of 40, is also associated with an increased risk of heart disease. And a lot of people who are seeking kind of treatment to treat the symptoms of menopause consider taking hormone replacement therapy, such as estrogen or combined estrogen and progesterone therapy. And you might think that since estrogen is so protective in the body, that these therapies would be as well, but they actually have their own associated risks. And estrogen and progesterone therapy specifically increases the risk of heart disease. And we have a webinar on menopause and the heart that discusses these hormone replacement therapies and discusses the effects of menopause and the heart a bit more in detail. But the large takeaway is that menopause very much affects other systems of the body.
If you just backtrack a little bit, it's actually kind of important to realize this, is that the average woman goes through at menopause around the age of 50 or 51. If it happens 10 years earlier, around 40, your risk of heart disease goes up. And we know around the time of menopause that your blood pressure tends to go up, the bad cholesterol tends to go up, and the HDL cholesterol tends to go down. In some individuals, there's actually a dramatic change. And we're starting to understand that. So I've seen quite a few women who develop marked rises in their cholesterol after menopause. And it looks like I'm sure there's a genetic factor behind that. We don't know that for sure. So really important to keep track of your cholesterol, but also during your time of menopause. And as you point out quite nicely, Dong, is that menopause is not just a sudden day. It's not a day unless it's induced by surgery. It's a gradual change. And initially, when I started practicing physician, I used to give hormone replacement therapy because it actually lowered the LDL cholesterol. And I thought it was a good thing to prevent heart disease. But we found out the exact opposite, that all forms right now of hormone replacement therapy after menopause increases the risk of having a heart attack, increases the size of stroke, because one of the things that estrogens do is they cause increasing clotting problems. So we know that estrogen actually increases the risk of breast cancer. That we knew. It does protect the bones against osteoporosis, but we have much better solutions to do that. It actually, hormone replacement therapy increases the risk of heart disease and clots and breast cancer. So the wisdom right now is that for women who have symptoms of menopause that do not respond to other measures, you can go on a hormone replacement therapy, realizing it will increase your risk of having a heart attack or stroke. You want to be on it for the shortest period of time. And one of the things that I learned recently, there is a randomized controlled trial that women who are suffering through menopause, that going on a plant-based diet and having half a cup of soy every day decreases the amount of flushing and the severity of hot flushes significantly. So that's actually a healthier way of going through menopause. You'll actually lower your cholesterol. In fact, those women lost 6 pounds compared to people who didn't go on the special diet. So there's different ways of doing things. So I think of hormones replacement therapy at the time of menopause is something I'd like to try to avoid if possible. And certainly for the dryness, the vaginal dryness and things of that nature, that local creams, estrogen creams can be very helpful. So there are many solutions. And I try to avoid hormone replacement therapy for as much as I can at this stage, but realizing that they are extremely effective at decreasing menopausal complaints. So that's very much an individual decision. And people are using different forms of estrogens and progesterones right now in the hope that they are safer. I'm not sure we really know that at this point in time. So I would consider that any form of hormone replacement therapy after around the menopause increases the risk of heart attacks, strokes, blood clots, breast cancer, for instance. So that's my take on it right now, but I'm still going to learn and change because again, when I started medical practice, I gave women hormone replacement therapy in the hope that it would prevent heart attacks and strokes, but it did not. It did the exact opposite. So we're learning all the time, and thank you for sharing that. Go ahead.
Right, so Dr. Curnew brings up a really important point. This is exactly why we need to talk about menopause, have this conversation with your physicians to ensure that your needs are being met and to ensure that you're feeling well, but also that you don't increase or affect your risks of getting heart diseases. And it's not just heart diseases, but this affects mental health as well. So the fluctuations in hormones in menopause can lead to mood swings, sleep disturbances, and also make people more susceptible to depressive symptoms. And as you can imagine, this can very much affect other facets of life, such as it can be an additional stressor, it can affect relationships and just involve social health as well. There's also other aspects of health that menopause affect. It's been noted that women who have undergone menopause have increased weight, and weight is a risk factor for a lot of different chronic diseases, as we mentioned previously. And also, people who have undergone menopause are more susceptible to osteoporosis. I'll talk about that a little more in a moment. But the reality is menopause can affect so many aspects of life, and it is absolutely crucial to be talking about it. And so I just mentioned that osteoporosis risk increases significantly with menopause. And you might be thinking that, okay, so that's something that we worry about when we hit menopause, but that is not true. So osteoporosis prevention starts now. It's true that women who have had menopause have more cause to be worrying about osteoporosis. However, it's important to keep our bones strong so that when we do hit an age of menopause, that osteoporosis is not at the forefront of our concerns. So some recommendations for osteoporosis prevention include doing weight-bearing exercises as well as resistance exercises. And these are just to ensure that our bones and muscles are constantly strong. And it's also important to keep a balanced diet. Some of the important nutrients, micronutrients to take into consideration to prevent osteoporosis include calcium and vitamin D. And so for people 50 years of age and under, women specifically 50 years of age and under, it's recommended that they take 1,000 milligrams of calcium a day. And for 51 years and older, it's 1,200 milligrams. And for vitamin D, the recommendations are a little bit different. For people less than 70 years of age, it's 600 units. And for women 71 years of age or older, it's 800 units.
Here's something really important. If we just keep this slide here. So yeah, you just go back one slide there. Is that so for bone health, you mentioned we have exercise, resistance and aerobic, calcium or vitamin D. What do you think is you get the most benefits from? If you had to pick, where do you get more bone protection? And does anybody know? What do you think? Well, it turns out is exercise is probably most important. That maintains your bone health. Other things is that vitamin D is only helpful if you have a low vitamin D level. If your vitamin D level is normal, you don't need vitamin D. And there's actually 3 trials that came out last year that showing really no advantage to vitamin D if your levels are normal. So everybody should think about getting a vitamin D level or spending a little bit of time out in the sun. Now in Canada, we have trouble during the winter months. The best time to measure your vitamin D level is early spring, just after winter's over. And again, the ideal level is 75, less than 30, you really have severe deficiency. And so that's important. Getting good calcium is important. And there's a couple ways of getting calcium. And next slide, please, is that so traditionally we use dairy. What you can see is that these are plant-based sources of calcium. And calcium is a controversial area. Taking calcium pills and vitamin D pills may actually increase the risk of having a heart attack. That's still debatable. But getting calcium naturally from food is if you get this more less rapid fluctuation in calcium, and it's actually better. So you can actually use dairy if you want to. Some people feel that dairy calcium may be associated with increased prostate cancer and breast cancer. And that you can get calcium from more plant-based sources. So for instance, soy milk has the same amount of, fortified soy milk has the same amount of calcium as a glass of milk. The only milk that I drink is basically skim milk, and I'm drinking a lot less dairy product. I'm using more fortified, like chia seeds. I grind them up. You can see that 2 tablespoons or teaspoons, sorry, is 200 milligrams of calcium. I put I have about half a cup of soy on a regular basis. I live on a farm, so we have soy, and I just soak them, and I just put them in the Instant Pot or just cook them up, and I just throw them in everything. Rich in calcium. And so these are, other ways, from white beans to chia seeds, soy are other ways in enriching your diet in calcium. So getting at least 1,000 milligrams of calcium naturally through foods are the best source right now. And anything else you want to say about that, Dawn?
No, very informative.
And one more thing, if you have severe osteoporosis, medications are very useful to prevent bone fracture rates. And so they're much more powerful than the vitamin D story, much more powerful than calcium supplementation. So if you have very thin bones, you need medications to strengthen your bones. And calcium is one of those micronutrients that many of us are deficient. And encouraging you to get your calcium from food. And remember, starting around your early 20s, you start to lose bone loss. And the best way to decrease bone loss is exercise. So please, another plea for exercise. And one more thing about exercise I just learned is that intensity of exercise is important. And the best way to actually delay Alzheimer's disease, guess what? Exercise, and vigorous exercise. It's important for that. So I'm playing squash tomorrow night, and I'm thinking about going climbing the stairs tonight before on the way home tonight. So anybody wants to join me for some stairs tonight? Half an hour after this webinar, I'm on my way. I just have to do a few more things in the office. So and a little bit of snow, that's good, and a few little stairs. So great, keep going. And that will strengthen my bones, and yours too as well, and help delay Alzheimer's.
Right, and also prevent osteoporosis when you do hit menopause. So the takeaway from this section is that menopause is it's a normal process, but it can be really complicated, and it's really important to understand its implications on health. It's important to speak to your doctors about menopause, especially if it's affecting other facets of your health, but don't be afraid to involve other people in your support network as well. Talk to your friends and family, let them know how to best support you during this time if you're going through menopause, and open the conversation. Talk to people who've experienced menopause, talk to people who have yet to experience menopause. Share wisdom, address fears and concerns. So this is the best way to deal with the crisis we have. And our next section is going to address myths about body image. So we just discussed a little bit about how important it is that we maintain a good BMI, a good weight, because being overweight and obesity, it's associated with a number of chronic diseases. And so it's a common idea that it's okay to be harsh on my own appearance. It's okay to be harsh on ourselves and think that, okay, I'm not where I am right now, and just get really down and out and beat yourself up about things like that. However, body image has its effects on health as well. 91% of women, unfortunately, are unhappy with their bodies, and having a negative body image is going to increase the risk of people experiencing eating disorders. And women actually have eating disorders at more than twice the frequency that men do. And certain eating disorders that involve having a negative body perception include anorexia and bulimia. So these are mental disorders, and they would affect their lives in very many ways, add stressors and affect relationships. However, on a physical side, and specifically a cardiac side, anorexia increases the rates of sudden cardiac deaths, and people who are anorexic also have higher likelihood of being bradycardic, which means they have a really slow heart rate. And for people with bulimia, they have increased risk of arrhythmias and palpitations. And so beyond the negative effects of body image on health, let's talk a little bit about the positive effects. So having a positive body image is associated with less depression, with fewer unhealthy dieting behaviors, and with higher self-esteem. So just in general, having a positive body image is much better for your mental and physical health. So this sounds a little bit contradictory. I just told you that being overweight and being obese can lead to a number of unhealthy outcomes, but I also just told you that being unhappy with how you look right now can lead to bad health outcomes as well. But it's actually not as contradictory as you might think, not just regarding weight loss, but with many things in general. It's okay to recognize that we have a ways to grow, that we have somewhere else that we want to be, that we have a goal to strive for, and still be okay and still be happy with who we are right now. It's important to acknowledge and love ourselves as we are currently, while working towards a better version. And I also wanted to acknowledge that social media plays a huge role in toxic beauty standards and contributes a lot to poor self-image that can be damaging to mental and physical health. And that it's really important to make sure that weight loss is happening with the intent of improving your health and not to match any of these toxic beauty standards. I personally have been guilty of scrolling and then seeing a lot of different people who look like they just walked off the runway. And it's really easy to start thinking about ourselves as, oh, we're so far from that, we should try to be more like that. But personally, I look at the people around me, and this is going to sound really corny, but I see them as really beautiful, not because of how close or far away they are from these idealized media images, but because of the way that they act and the values that they hold. Those are just personal experiences, but I'm not an expert on any of this. However, there are experts and better resources that you can turn to. So specifically about mental health and eating disorders, we have Body Brave, which is a Hamilton charity for eating disorder treatment and support. The website's linked here. Center for Addiction and Mental Health can also address a lot of concerns around mental health and self-image. And regarding the rest of this webinar, I also came across this resource called Healthy Women. And this is essentially a health resource for women aged 25 to 64. So a lot of people in this age range would be experiencing menopause. And not only is this a good resource full of information, but also this website shares a lot of stories and experiences of women as well, which I think builds a wonderful community. And we also want to acknowledge that there is a variety of health myths that we did not discuss today. This includes a lot of myths regarding sexual health, contraceptives, puberty, and reproductive health. And it's not because we were afraid of the stigma that we didn't talk about them, but due to time limits, and we decided to prioritize the myths that were more relevant to Dr. Curnew's patient population, a little bit towards the older population, but here are also some resources that address these topics, including sexual health, contraceptives, and I also included the YouTube channel, which I thought was really informative. And that is it for me. Thank you for listening to our presentation.
Fantastic. So, it's, we started off at one time believing that women didn't have as much heart disease than males. We found out that's not true. Women have just as much, if not more, especially as we get older. Unfortunately, women outlive men, and women develop heart disease later in life. The diagnosis of heart disease can be more challenging, more difficult. And I think, is that, but really important, the best way to treat heart disease in both males and females is prevention. And 8 out of 10 heart attacks is preventable. So I'm striving to be as skinny as I can, keeping my body mass index between 20 to 25. Having your own blood pressure machine, keeping your blood pressure between 110 to 120 systolic range is ideal. Realizing that once it's over 130 to 140, you need to think about medications if your systolic is elevated, diastolic over at 90 range. Knowing your cholesterol, knowing your blood sugar is important. You mentioned things like, bone health. And so to me is exercise, 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 and enjoy the exercise. Is that mental health, I think activity is really important. If one is having menopausal symptoms, I really impressed that I would try plant-based eating and having a half a cup of soy every day to that. And it actually shows in randomized trials to be helpful. And certainly if one needs to go on hormone replacement therapy after the menopause, that's important. But take it for the shortest period of time if you can, because it does increase the risk of a heart attack, stroke, blood clot, breast cancer. Getting good nutrition, good sleep, and good support is very, very important. And thank you for sharing that. One of the things that we didn't touch on this webinar, we touched on others, is that pregnancy gives you great insight what's going to happen to you in the future. So a woman who develops hypertension during pregnancy, likely to have hypertension after pregnancy, and more likely to have heart disease later in life. Women who develop gestational diabetes during pregnancy. Pregnancy is very stressful on one system. Is that you have a higher incidence of heart disease, and more likely to have diabetes later in life. We now know that not everybody can get pregnant, and that just in vitro fertilization carries risk for vascular disease as well. And so lots of things we have to learn about this. But so wonderful that we can actually make better diagnosis and better prevention. So I just want to thank the entire team for this presentation. Any thoughts from anybody? Stuart, what do you think?
Oh, well, thank you. I wanted to join this webinar specifically because, yeah, I have many great women in my family who I care a great deal for, mom, aunts, and so of course they're at an age now where these types of this type of information is relevant and important to them, and I always like to share the ones that I think that my family could personally benefit from. So I would have wanted to learn a little bit more about this so that I could have conversations with them if that ever comes about, especially with my mom, and share the video with her. But I could also personally relate to the webinar as well in some senses, especially with the one about mental health and body image. Sorry, I'm just gonna mute the background noise just for a moment. Sorry. Yeah, so just the topic of like body image as well. Of course, like I've personally had bouts of feeling low self-esteem and things like that, and so of course it's really important to recognize the interplay between body image and perceptions of yourself and the impact it can have on your physical and mental health as well. It's something that I'm always working towards improving, and one way that I have worked to improve it especially is actually trying to find an exercise routine that I really enjoy and works for me, because I find whenever I do some sort of physical activity, I just really feel less guilty and I feel good about myself at the end of the day. And oftentimes I feel like that's one of the best things in terms of making me feel good about myself in terms of my mental health. And it's something that it's been a battle that I constantly try to strive towards, but I'm working towards finding the regime that works best for me. I also didn't know, Dr. Curnew, as you said, that around my age, my bones are starting to get to that point now where they deteriorate. They're not getting bigger. They're starting to go the opposite direction. So just another thing to add to my motivation list for why I want to get a good exercise routine that works for me consistently. And I just wanted to thank Dong and Hinia for putting together this webinar tonight. And thank you.
I think that was wonderful. These ladies made it to the point, not long-winded like I tend to do. So I want to thank you for sharing some really important facts. this is something that we need to share with others. And I thank the whole team for putting this on. Wonderful.
Awesome.
I've been there. Are there any questions or comments from anybody there?
I wanted to know if you take the hormone replacement therapy, because I know somebody who takes it and then they take the cream, but they have weakened bones, so then they have to take 1 pill a month for their bones. Would taking the hormone replacement therapy increase weakness of her bones?
Actually, hormone replacement therapy increases the bone mass, so it's actually good for the bone.
Okay.
The problem is it has a lot more negative effects than good effects. So we have other medications that are better and safer for bone health, and they're called, there's a category, the whole category of medication called ligaments, and so that's what I would do for bone health. I would not use hormone replacement therapy for bone health. It increases risk of breast cancer, increases risk of having a blood clot, increases risk of having heart attack and larger stroke. So we have better ways of doing that. And now, if for vaginal dryness, estrogen cream gets absorbed to a much lower degree. And so that's important. We also mentioned quality of life. So if a woman is going through menopausal symptoms that are quite severe, that don't respond to conventional medication or conventional lifestyle changes, then certainly willing to say, listen, quality is important, and therefore you go on a hormone replacement therapy. But there's a but to that. And and one of the things that many people feel that are said that the newer estrogens and progesterones, or the patch forms of estrogens and things that we're using, are safer. The answer is we hope so, but we don't know so for sure. And so I would assume that they're not. And I'm quite impressed with what you can do with soy and plant-based eating. You know, having your fruits and vegetables, your leafy greens are vasodilators. They give you nitric oxide production that opens the vessels. And we know that estrogens, or you get estrogen-like molecules from soy products that are actually safe and vascular protective. Japan, for instance, eats a lot of soy products, and they don't have much in the way of osteoporosis. More importantly, they don't have the same degree of menopausal complaints as we do in North America. So lots of things we can learn.
See, it is helpful, because my friend, like, she takes all this stuff, but I've never had a hot flash, so I can't relate to her, because I don't think about, I got too many other things to think about than menopause. But like, she gets all like sweating buckets and she's hot, and so now she's getting all this medicine. But I'm like, I don't know if you should like take all that stuff. Like, just don't think about it.
Well, there's
Like-
an individual decision to make your doctor, and certainly for menopausal symptoms can be very severe, very disabling, and in that circumstance, it's worth considering. So those are, you have to look at the pluses and minuses. The hormones are very effective decreasing symptoms. One thing I encountered a woman that, she said, I've been taking estrogens for the last 10, 15 years because it improves my quality of my skin. I'd rather have ugly skin and good heart and less stroke and less cancer. And so I look what's inside. Some people look at what's on the outside. So you have to decide, you want to look better or you actually want to be healthier. So think about what's important. And when Dog says that beauty is, the quality people have, and that's much more important than what your vessels look like, and how much cancer you have is really important too as well. So choices. My wife had to take hormones for many, many years. She's very troubled by symptoms, and she tried all sorts of things, and it made a huge difference. But I understand that's an individual decision.
See, and it's hard. I know a couple of people who have very bad symptoms, but I don't have any symptoms. I never did have any symptoms, so it's harder for me to relate to them. Like, when I see,
Everybody's different.
I guess I'm just lucky that way, thank gosh, because I see some of the things that they go through. Like, 1 minute they're nice, then they're crazy, then they're okay, and it's I feel bad for them, like I do, but I just like, and sometimes they're mad at me because they're like, well, you don't get anything, but I don't know why that is, but I guess everybody's different, right?
Absolutely. Listen, that's thank you for your comments, and don't forget is that heart disease in women is a common problem. It's treatable and preventable, and the symptoms can be different. So with that in mind, I think we're going to say goodnight to everybody. And I look forward to looking at this again, once again. And thank you all for listening. Thank you so much, everybody.
Thank you.
Take
Night
care.
now.
Everyone.